My name is Neil Spenceley. I'm the clinical lead for Paediatric Patient Safety. This is a short presentation on the PEWS chart and the education package that came with it. As you know, PEWS has been rolled out in a national form over the last 6 to 9 months. And we're very grateful for all the boards and people at the front line who have taken this on, which is most of you, which is fantastic. And that's a real sort of credit to Linda, Roger, Leslie, Darlene, Kirsty, and everyone else who has, and Sharon, who's taken on this work, and that is continuing. So, I suppose, what does a PEWS chart do? Well, as you'll remember from some of the previous WebExes, then there's a great quote from Pat Brady, is that patients don't suddenly deteriorate, healthcare professionals suddenly notice. So I suppose that a PEWS chart is a way of allowing people at the front line to maybe discover that the child is unwell or deteriorating. It's not the only way, but it assists in that discovery. Now, the number itself on its own doesn't do anything, and there's that recognition as well that you can have a high number with a child that looks well, or you can have a low number, even 0, and the child looks terrible. So there's something else that needs to happen in order for it to be effective, and that is the way that things are escalated. So if the chart is used in combination with clinical acumen, clinical concern, and it is in an environment and a culture that allows people to raise their hands and initiate escalation, then it can be quite a powerful tool and has been shown to reduce hospital arrests and PICU admissions. So the PEWS is part of a bigger system, improving this situational awareness, which we've discussed before, but I'll touch on again, which is the what, the so what, and the now what. So what do you think the current situation is? So you may have in front of you a child being breathless. So what? So what is our current understanding of this situation? So the child has a known history of asthma, and it's summertime, they've got a dog, and so perhaps the child is having an exacerbation of asthma. Well, that's fine, but now what? What do you think might happen in the next 10 minutes, half an hour, 2 hours? And so, well, the child could deteriorate, require more oxygen, perhaps intravenous bronchodilator, pressure, or moving to another center. So if used reliably, the PEWS chart can initiate increased frequency of observations, bring expertise to the bedside, and allow a sort of a discussion with the pertinent members of the team about the situational awareness of this child. And as you know, if you can predict accurately or semi-accurately what's going to happen, you can be prepared for that. And it also allows you to allocate a specific member of staff to that patient who knows that patient and is happy to review after a period of time to make sure that what you think is going to happen has actually happened in a manner that is commensurate with the therapy that you've given, i.e. the child is less breathless, less oxygen, less bronchodilator. So the first thing that you have to do really is choose which chart. And it's worth spending a minute or two on this because there's 5 different charts. The ones that predominantly people will be using are the first 3, so 0 to 11 and 12 to 23 months, and then 2 to 4 years. And it's just worth pointing out that it's not the 11th month or 12th month that you change over in the first chart. It's birth to the day before their first birthday. Similarly, in the second chart, it's to the day before their second birthday, and with the 2 to 4 years, we actually had to change this because initially it was 2 to 5 years, and people think, well, the child's 5 years old, we'll just use another chart. But in fact, we had to put it to 2 to 4 years. But remember, it's the day before the 5th birthday. So it's a common mistake at this area to think about the actual months and years and things, and people can get a little bit confused by that. So I say it's worth pointing out that the first hurdle to overcome is to choose the correct chart, and you change it the day before the birthday of the next chart that's going to be used. The chart itself, when you open up the form, is quite nice, and in the sort of the top left-hand corner, you've got the date, the time, the location. Put the name in as well at the top, and the Chi number, and it's been designed in a manner that is easy to use. So this is where the sort of human factors element of things has been taken on board. Human factors being not kind of human behavior, but it's designing a system which takes into account a wide variation of human behaviors, not just throwing out a chart which people have to adapt to. It's allowing the chart to be as easy to use as possible, recognizing that lots of different people are going to be using it, and recognizing that lots of different hospitals are going to be using it. And as you scroll down the chart, it's been done in a manner where you start off with the airway, and then you head to breathing, then you examine the cardiovascular system, so heart rate and blood pressure, move on to disability, environment, and then you end up with your PEWS score. We can look at that a little bit more in detail later on, but when you're actually marking the chart, remember just to use a dot. Many people have their own way of marking it, but I think a dot is probably the best because it's easy to see and it's easy to follow, and it doesn't get mixed up if you use a cross or a Scottish saltire or a fried egg or all these types of things, because they are difficult to follow. And as you'll know, in children, it's perhaps not the absolute number that is the most important thing, it's the trend, because we've got 5 different charts, the adults have 1. And so it's that sort of learning the child's physiology over a period of time and watching the trend of which way they're going is incredibly important. And if you use the sort of fine dots that you can look at easily, you can then trend the heart rate going up or down, trend the blood pressure going up or down, and that just makes it a much more obvious visual clue that something is happening. Again, taking into that sort of human factors, how do we make it easy for the frontline people to notice that something's going wrong? You'll also notice that underneath the SpO2 is oxygen. Now we've put that in, but we haven't scored it. So you can mark down how many liters per minute the child is getting, but also the mode of delivery, so face mask, nasal cannula. And we haven't scored it because it's difficult to score, but we have added it in because we think it's important, because again, it can show increasing amount of oxygen requirement to maybe maintain a saturation of 93, 94%. So 93%, even though it might be going along the same line, is different on 2 liters of nasal cannula as opposed to 15 liters via a trauma mask. So again, these are things that people were kind of wanting, and I think it's a good idea to have that element of intervention, particularly with oxygen requirement, because the respiratory component of our children is probably the one that's going to go off the most, and the one that we should be, really sort of paying attention to. Similarly, blood pressure has a sort of a slight quirk to it. So we're going to plot the systolic and the diastolic, but score only for the systolic component. And again, that's important because you can, if it's low, then there may well be impending, cardiovascular collapse and poor oxygen delivery. But if it's high, then that can be associated with certain drugs or endogenous production of steroids or renal problems or even cardiac disease. But it's important because if you've got a very high blood pressure, then the arteries in your body have to shut down and squeeze quite tightly in order to generate that blood pressure. And to my mind, if you've got a very high systolic blood pressure, it might mean that there's decreased oxygen delivery to certain parts of your body because the arteries have been very tight in order to maintain that blood pressure. So use a dot so you can trend it easily. mark down oxygen, how much, and the mode of delivery. And when you're doing the blood pressure, do systolic and diastolic, but for scoring purposes, then it's systolic only. Then we can add up, we score the chart and then add them up. So we deliberately went for 0, 1, and 3, largely because with a 2 there was a little bit too much ambiguity, and putting the current system into sort of various data machines, the sensitivity and specificity using this method has actually come out pretty well, as we've described in previous charts. So it scores nicely with regards to patients being unwell, but also it's easy to use. So you can get some charts which are a little bit more accurate, and that's fine, and that's good, but they are more difficult to use and to fill in correctly and score correctly. So we've elected for this, so obviously 0 is white, 1 is yellow, and 3 is red. And then you can look at your scores and tot them up, and here we see that there is a PEWS of 6, and it's important to initial that. So who was the person seeing that, and if the if the score is abnormal, then have a jot down about what time the medical review occurred. And these are sort of important things for if we're looking to gather, specifically for data, what was the time between, the concern raised and it being addressed? How do we manage to improve that element of escalation, the interface between concern and bringing expertise to the bedside, that sort of cultural element of it? So once you've added up the score, then jot the score down, initial, and then date. So obviously, if we score a 6, then we can put it into our level of escalation, and you can see that 4th box down on the left, then it will be in the 5 or more. So the level of escalation will be 3. Now, we've deliberately not written any specifics about the levels of escalation because we recognize that these are going to differ, not wildly, but they will differ depending on the resources and geographical location of the child and the services that they have accessed. So I suppose the level of escalation for, in Shetland is going to be probably just directly to consultant level, whereas the level of escalation for me in intensive care and there's somebody going off of the wards, there'll be more junior staff and then escalating to perhaps consultant and then me. So, and also the level of intervention that we can provide is different. So I think that whilst they're not going to be wildly different, and I think this is something that we're going to get some ideas and thoughts on over the next couple of months, so there may well be some similarities that we can then roll out through the chart or have a think about how we're going to achieve that appropriate escalation. We've deliberately left it so that people can fill in their own escalation plan. And I say this is something that we would hope to follow up over the next wee while through dialogue and the deterioration WebExes, to have a think about, are there commonalities and are there things that we could perhaps improve on? And if they are, what would they be and how would we achieve that? So the red box is obviously blank, but these are the things that we should think about. Don't forget, though, that if there is a red, if there's a dot in any of the red zones, then that is automatically a 3. So whilst that was, and one of the other purposes of doing that was if there is something which is a significant outlier within that physiological parameter, then there should be a degree of escalation commensurate with the local capability. But similarly, even if there's a PEWS of nothing and there is clinical concern, and you can see there's a box at the top that you've got a C for a carer concern, or you can put an S for staff concern, or you could put both, then that overrides everything. That means that you can override your sort of escalation pathway. You don't have to wait. You don't have to wait for permission from the chart to reach a certain number in order to call for expertise. You can bypass that completely if you have concern, or if you have any of these concerns, which we've sort of jotted down in the red box. So as you can see in the top, its concerns include but are not restricted to, and that's important because your patient may not have any of these, but you still are concerned. Your experience and your expertise, your gut feeling has just decided that this child is not well, but you're looking at a PEWS, which is 0 or 1 or 2, and it doesn't seem to be moving, but you still are concerned. These are the things that you can override the system at any point because you're anxious about this child, and get appropriate help. And the help will then decide this as a situation, improve the situation awareness. What do you think is actually happening? What do we need to do now? Or what do we think the level of physiological deterioration would be in order to prompt the next intervention? And that intervention has to be decided and discussed. And if any intervention has started, then when are you going to review this child and who is going to do it? And it's likely that it should be done within an hour or a certain time frame. And if things are progressing in the right direction, then great. If things are not progressing in the right direction, then the next part of the plan and discussion and dialogue has to be initiated in order to make sure that the child gets the best care. So, yeah, start off with the correct chart for that patient. Make sure that you fill in the name and the date of birth and the CHI number. Remember about recording the observations 0, 1, and 3. Any of the scores, that scores 3, will be in the level of escalation 2 box, which should have some sort of escalation to an appropriate member of staff, senior AMP, senior registrar, consultant, whatever you think is appropriate for the local infrastructure and capability. Even if they're not scoring high or scoring at all, but if you have clinical concern, then it can override the chart and it can override anything. So therefore, you can ask for help and ask for people to come and have a look at the patient. Now, there are many different patients that we come across in pediatrics, and some of them really don't conform to any of the norms, and so they have their own sort of private physiology. And that might well be children with neurological disorders who can't mount a temperature, whose normal temperature maybe is 35. Children with cardiac disease, particularly cyanotic heart disease, so they're blue. So the saturations normally may be 70, 75. Yet if you put that on a normal PEWS chart, then they alert you every time you do a set of observations. So in conjunction with the clinical team, if there are children who have certain parameters that are out with the norms but are normal for them, then you can chart them in this box and again sign and date it. So therefore the escalation will be appropriate for that child and not inappropriately frequent if you were to plot it on the normal for the normal set of variables. And then finally on the chart, if the child is unwell, is hot, and you think that this child might be septic, then it gives you some guidance about what we should be doing, and that's really linking into the Sepsis 6 program. So it's kind of asking a different question. If this child is unwell, you have identified this child as unwell, either via a PEWS chart or either because of clinical concern or a gut feeling, then the question is, can we shoehorn this child's physiology into sepsis? It's thinking, well, why isn't this sepsis? And if you can't convincingly convince yourself that it's not, then maybe we should be thinking about going down the Sepsis 6 route, which is giving oxygen, gaining access, cultures, glucose and lactate if able, giving antibiotics, consider fluid resuscitation, and we would give 20 per kilo over 5 to 10 minutes. If you've got to 40 per kilo, then have a think about this child might need more. Maybe we should be making up the inotropes now, and we've suggested in Sepsis 6 that should be adrenaline. But if you're, your own local protocol may say differently, but adrenaline's a nice drug. It works effectively. It doesn't cause too much elevation in your heart rate as well, which can be confusing. But also that is something to maybe gain extra expertise, such as local intensive care input or anesthesia, because this may require improved access, use of sort of exotic drugs, which people may not be that familiar with, or going to the next stage of intubation and ventilation. And in summary, all these things can be seen on the WebEx chapters, including this thing here, the one that we're doing at the moment. But there's quite a lot of WebExes that we did in sort of late spring, early summer, which bring the elements of the PEWS charts together. So that's sepsis, deterioration, and actually the use of PEWS charts itself. So they're not very long, but they've been done by external physicians from around the world. So we've had Pat Brady from Cincinnati, we've had Benita Patel from Texas Children's in Houston, and we've had Damon Rowland, who is from Leicester, talking about PEWS. So if you have time, then have a look at those as well and see what you think. We would love to hear your feedback. And sometimes people have been using it as part of a sort of an education package. They'll watch the WebEx and then have a local discussion. How do we think we could implement this locally? How do you think it's going to affect how we chart and use our PEWS charts? And I think through the next year or so, then there'll be sort of collective thoughts come together about the PEWS charts. How is this finally going to look? This is kind of like the first iteration. So to a certain extent, we've tested it in certain boards, but now we're testing it in all boards. Any questions? You can find me at nhs.net, so neil.spenceley at nhs.net, and Leslie McFarlane, the real brains behind the program, is available on email, and we can get back to you, and we would love to come and see you as well, and see what good work you're doing. So that concludes that WebEx chapter on PEWS, but it's one of many which would be worth dipping into when you have time. Okay, thanks very much.